Good morning. I wanted to go live this morning because I wanted to talk about what you can learn from your basic blood work. One of the things that patients have a hard time with is getting blood work done. If I've recommended, getting certain tests or getting specific things looked at, sometimes it's just not accessible. And one thing that is accessible and I think super underrated is the blood work that we get done, that basic panel. So I'm going to say a couple things about this live. First, there's going to be a lot of information and it will be recorded and posted on my Facebook, on my YouTube. And so if you want to go back and watch it and kind of go through it with your own blood work, that might be the way to go. But I want you to understand some of the things you can learn from the standard blood work you probably already have. I feel like we're underutilizing the information that we're given in standard blood work. And I feel like this could be a helpful strategy to kind of start to get an insight into our health, into what else we should look for, into what else we should ask for if you are struggling with symptoms. And I'm going to give some cases at the end. And so let's get into it. Most people have had blood work done in the last, let's say, year. Usually we do like our physical. So today I'm going to talk about the most basic stuff. We're going to talk about what we can gather from the lipid panel. So like your cholesterol panel, from the CBC, which is your complete blood count, which has kind of like that hemoglobin, white blood cells, red blood cells, etc. And we're going to look at the liver enzymes. And I'm going to give you some insight that you probably didn't already have as it pertains to this. Just as a disclaimer, the units I'm using are Ontario, Canada units. So if you're watching this from YouTube or anywhere else and you are not located here, you're going to have to do your own conversion there. Okay, so this is what we're going to cover in this live. We're going to talk about the lipid panel, the complete blood count, the liver enzymes, and pattern reading. Because realistically, when your lab report says normal, it just means that you are within, the range that they've set out. It doesn't necessarily mean things are amazing and healthy. It doesn't mean that you have nothing to worry about. And so I want to use this time to kind of look at some of the pieces that we can gather from your basic blood work that you probably have on LifeLabs. So let's talk about the lipid panel. So first and foremost, just to understand what that means, a lipid is basically a fat. Your body makes fats and uses them as building blocks and fuel. The lipid panel is a test that measures different types of fat and carrying proteins in your blood. Some of them cause damage over time. Some of them are protective. I want you to understand the difference in the different pieces of the lipid panel and why the numbers you see might not actually be the entire story. So the first thing we're going to look at is LDL and HDL. So first and foremost, cholesterol is a waxy substance your body produces and needs. It's used to build cell walls. It's used to make hormones, which lots of people don't understand or know. It's used to produce bile and for digestion. And your body makes most of it in the liver. And when it comes down to this being problematic, the problem isn't the cholesterol itself. The problem is actually how it travels through your blood and what it does to your artery walls along the way. Cholesterol actually can't dissolve in blood on its own. It's like trying to mix oil and water. So your body actually packages it into little protein-covered bubbles. These are called lipoproteins. So we have LDL and HDL. They're both types of these bubbles. So LDL, the job is to carry cholesterol out to your body's tissues, and HDL carries it back to the liver to be cleared. And so HDL is primarily called your good cholesterol because it is the one that brings it back to the liver to get cleared. But it is a little bit more complicated than that if we're looking at LDL and HDL. So one thing I want you to know about LDL is that it is not measured. It is actually calculated from a formula. So essentially, when we look at our blood panel, we're not saying, oh, this is exactly how many LDL you have. This is just based on the overall calculation. And we know that this formula is going to be inaccurate when your triglycerides are too high. So another form of your lipid panel, your triglycerides, if they're elevated, that LDL is not going to be accurate. And then there's some targets for what we want to see in the general population versus someone with a heart disease history. And then over 4.9, we want to screen for a hypercholesterolemia. Now we have HDL. This is primarily the good cholesterol, but there is a little bit of a catch to that because when we look at research, we see more is not always better. There is a sweet spot. So high HDL, there was a study that looked at HDL. There was a drug that basically forced HDL to increase. And what they found was that when the drug forced HDL higher, it actually didn't have the same benefit as naturally high HDL. And we do know that HDL from a 2.1 to 2.3 or higher is linked to higher mortality in large studies. So more is not always better, but I do like to see it at least above 1.3 because that's going to be more protective in the overall cholesterol panel itself. And then we have your triglycerides. This is your fat fuel reading. So triglycerides are the fat your body makes from excess calories, specifically from sugar and refined carbohydrates. So when you eat more than your body needs, it converts the extra into something called triglycerides and then sends them into the bloodstream for storage. So this is like your body packing leftovers into the freezer. High triglycerides usually mean the freezer's getting too full too often. So when someone's triglycerides are high and their HDL is low at the same time, this is actually a very reliable sign that the body is having trouble managing blood sugar, even if your blood sugar test came back normal. So this is the first thing I want you to use from your basic blood work panel is the triglyceride to HDL ratio. You can calculate it by dividing your triglycerides by the HDL. And then this ratio is a really good marker for insulin resistance. And this is, again, available on your standard panel. So if you divide your triglycerides by your HDL, you can see what your insulin resistance marker is at. So optimal would be less than 1.7 for triglycerides. Elevated is 1.7 to 5.6, and at a serious risk is 5.6. And when we look at the triglyceride to HDL ratio, women, we want it to be less than 0.7, but there is a range. I'm going to give you a resource at the end that you can use to help with all these calculators. But there is a range, and we can use this number really effectively. If we don't have something like an insulin glucose challenge or insulin readings, we can use the lipid panel to help us understand insulin resistance. The other marker we can use that's on your panel is called the cholesterol HDL ratio. So the triglyceride HDL ratio is not on the panel itself. You have to go calculate that. But the cholesterol HDL ratio is something you'll actually find usually at the bottom of the panel. It's the last number. And that's also an indirect marker for insulin resistance. So I typically like my patients to be under 3.5, 3.5. And over that, we can see increase the insulin resistance. And so really what I'm trying to tell you today is how to interpret some of these patterns, how to make really good trends, because we can't look at one thing in isolation. We can look at how things are trending, what our risk factors are, what have we calculated them at, and how are they moving over time. So the triglyceride HDL ratio is one of the great ones to look at that. We can also look at the cholesterol HDL ratio. And then why do triglycerides rise? Well, we see excess sugar and refined carbs, excess alcohol, insulin resistance or metabolic syndrome. You'll see specifically in a lot of these panels, which might surprise you, that hypothyroidism comes up. And so again, you're like, my doctor, I swear I have symptoms of a thyroid issue, but everything we do is coming back normal. This is kind of a way we can look kind of behind the curtain and say, what is going on with the thyroid that we're maybe not catching in the direct thyroid panel? And then kidney disease can influence this, and certain medications, so specifically beta blockers, some HIV drugs can influence the triglyceride marker. Okay, next up is looking at something called ApoB. This is something that you probably have not seen on your panel. The marker most people have not heard of. Unfortunately, this is not something that is on a standard panel here in Ontario. You actually have to ask your doctor for that. We know that ApoB is basically, so when we look at LDL versus ApoB, LDL measures the cholesterol cargo inside the particles. ApoB counts the particles. And 1 in 5 people actually have an inconsistency. Their LDL looks fine, so the amount of cargo they're carrying isn't a lot, but the ApoB is high, so the amount of particles is high. So this can happen when someone has many small, dense LDL particles, each carrying less cholesterol, so less cargo. So the LDL looks fine, but there's a ton of particles, right? Essentially, we can think of this as ships docking to the artery wall. We know that every atherogenic particle carries one ApoB molecule. And so, again, when we look at this from an opposite perspective, if we had a high LDL and a normal ApoB1, this means we have large cholesterol rich particles, fewer ships, each carrying more cargo. So, really, it's about the number of times we're having to essentially dock the ship. So, if we have a bunch of particles, they're not carrying a lot, but there's a ton of them, that can be more problematic than less particles carrying a little bit more, right? So basically, the key take home point here is if you have high LDL, it might be worth looking at ApoB, because then we can see, how much at risk am I? If your ApoB is high, but your LDL looks normal, you actually might be undertreated. And again, if your LDL is high and ApoB is normal, you might be lower risk than you think. And so this is an important marker to look at. And largely, there is a genetic component to ApoB. So when we look at ApoB, the mechanism and the targets, so basically, why do the particles matter more than the cholesterol content? So LDL particles cause plaque not by floating in your bloodstream. So when I'm talking to patients about their LDL and their LDL is high, they're often freaking out like, oh my God, my cholesterol is high. I'm going to have a heart attack. But it's not the LDL floating around that causes the problem. It's by it crossing into the artery wall, which is known as the intima. The particle must fit through the arterial lining to enter. When it's inside, it oxidizes, triggers inflammation, and then macrophages come and engulf it. This becomes a foam cell, and this creates a plaque. The number of times this happens per day depends on how many particles are circulating, not necessarily the amount of cholesterol in them. So when we look at atherosclerosis or these plaques being created in your arteries, it is more of a particle traffic problem. So we have more particles doing this, creating more problems, right? And we do know that ApoB is largely genetic, right? The amount of particles you carry is a genetic thing. And so ApoB can tell you whether your treatment is actually reducing particle count or just moving cholesterol between particles. LDL cannot tell you that, okay? Now, the APO targets in the general population, I have at the right-hand side here, 0.9. Someone with a high cardiovascular risk, you'd want it lower, 0.8. And someone with a very high risk, so for someone who had a prior myocardial infarction or is a really high family risk, then we want it 0.65. Again, it's not on every standard Ontario lipid panel. You have to ask for it. So this might be another layer, specifically in my postmenopausal, perimenopausal patients who are worried about their cholesterol. This can be a really helpful tool to just understand things a little bit better. And then we have something called lipoprotein A. And lipoprotein A is seen as the genetic wildcard. So this is like a special version of LDL that's been modified by your genes. It is more dangerous than regular LDL because it does two things at once. It contributes to plaque in the artery wall, and it makes blood clots harder for your body to break down. This is a largely genetic thing. And so if you are making decisions as to whether or not you need to have your cholesterol, for example, treated by medication, or, sometimes we'll look at a cholesterol panel and we'll say, okay, let's watch and wait, right? Based on all the other factors, let's watch and wait. Let's not medicate. Let's do lifestyle interventions. Let's do diet and exercise and all of the things. But when we have a lipoprotein A that's elevated, this changes the conversation and might lead us to getting treatment interventions a lot quicker than we would have otherwise. So about 1 in 5 people have an elevated lipoprotein A. Most of them don't know. And this is the explanation behind people who exercise, eat well, don't smoke, and have normal cholesterol having heart attacks in their 40s and 50s. And so I think this is a worthwhile marker to have tested. We know that about 90% of your lipoprotein A is actually set by your genes. Diet, exercise, and most medications barely move it. About above 125 significantly raises your risk for heart attack and stroke. This is independent of LDL, smoking, and other factors. This is where the genetic piece really plays into the picture. We know that elevated lipoprotein A specifically predicts your calcific or aortic stenosis. This is the narrowing of the heart valve, and that can require replacement. And you actually only have to have it tested once in your life. So if you have it tested and it's high, it makes sense that we do other, some of my patients are hesitant to do things like statins because they don't want to increase the risk of the side effects that statins have. And then, one of the things that I say is have your lipoprotein A tested and your ApoB, and we can understand what is the familial risk, right? A lot of times it's difficult because metabolic syndrome, insulin resistance, diabetes is so common, and it largely happens in people as they get older. And so sometimes it's hard to understand, is it genetic, or did my family member who had a heart attack and all the other things have poor lifestyle factors that contributed to all the things they experienced, right? And so this is a really good way to have, to understand this piece. And then when you understand this piece, you can know if your family member should be tested for this. Okay, moving on from the cholesterol, we're going to talk about the complete blood count. So we're talking about the red blood cells, we're talking about MCV, we're talking about ferritin, and hopefully you can get some really good insight from this. And a lot of people have the complete blood count and they see it as nothing. It's like they run through the list and they're like, normal, normal, normal. Typically the doctor will let the patient know, I'm looking at this to see if you're anemic. But there's a lot of other things we can really gather from a complete blood count. First of all, a complete blood count is cheap. It is cheap. It is easy to obtain. You're never going to have to argue with anyone to get a complete blood count done. It's like the standard of standard. And so this is why I think it's really important to have this conversation and to be able to gather information and insights from your basic plant panel that you for sure got very easily and or purchased very, inexpensive if you had to pay out of pocket. So first and foremost, we're going to look at the red blood cells and hematocrit. So red blood cells are the cells that carry oxygen throughout the body. You have billions. The red blood cell count tells you how many you have. And we know that hematocrit is actually the percentage of your blood that is made up of red blood cells. So if your hematocrit is 45%, nearly half of your blood volume is red cells. Now, the kidneys play an important role here. So again, if you didn't know that, your kidneys are constantly monitoring how much oxygen is being delivered. If your oxygen level drops, this can be from like a poor altitude. If you are traveling somewhere with a different altitude, this can be from poor breathing at night. So if someone has sleep apnea, take note because we can actually find some of that insight in the CBC. This can be from not having enough red blood cells. What the kidneys do is they send out a chemical signal called EPO, and this tells the bone marrow to make more red cells. Interestingly enough, testosterone does the same thing. It stimulates that same signal. So, for example, a man whose red cell count is constantly at the high end of normal or above normal is often producing a lot of testosterone. This is an indirect way that we can look at this. We also would want to be monitoring this on someone who is on testosterone replacement therapy. The sleep apnea connection is one a lot of people miss. Sleep apnea means you stop breathing repeatedly during the night. Every time this happens, your oxygen drops. Your kidneys sense it, they push EPO, and over months and years, your red cell count slowly creeps up. So if you have an elevated red blood cell, an elevated hematocrit, and someone who snores, someone who wakes up tired, someone who's not refreshed, this can often be a signal, the first signal that can hint that we need to dive deeper into maybe undiagnosed sleep apnea. And then we have PCOS, recently renamed as PMOS. These women often have elevated androgens, testosterone included. And so again, coming back to that same conversation, higher androgens stimulate EPO, which drives red blood cell count up. So if you are a female and you're like, I go to the lab and I get my blood work done. And every time I get my blood work done, my red blood cells are a little bit high. My hematocrit's a little bit high or maybe borderline. But I'm not, sometimes they'll say, oh, you're dehydrated. You're dehydrated. But ultimately, this can be, you could be dehydrated. Again, all of these patterns are signals. All of these patterns I'm talking about today are things that are going to give you more insight into how can I look at my overall symptom picture, what my blood work, what my basic blood work is telling me, and how can I make informed decisions about these patterns and about these trends. And part of that is I go to the lab, my red blood cells are slightly elevated. My hematocrit is like on the cusp or maybe even a little bit elevated. I'm not dehydrated. I have symptoms like excess hair growth, acne, hair loss where I don't want it. Maybe I do have PCOS, also known as PMOS. And that can be an indicator that you have elevated testosterone, right? So maybe you're like, I wanted to get my hormones tested, but my doctor won't do it. We can look at your complete blood count indirectly and we can say, okay, we consistently see these patterns, right? And so maybe it's worthwhile digging into your testosterone. And like I said, we're going to come back to a lot is hypothyroidism. A low functioning thyroid reduces EPO production, slows red cell production. Women are diagnosed with hypothyroidism 5 to 8 more times than men. And typically, we can look at these patterns that can lead us in the direction. Again, I talked about the lipid panel being a flag for thyroid. Again, this is not diagnosing a thyroid issue, but what it is saying is, I have this weird thing that's coming up. And then I look at my my other symptoms. I have a low normal red blood cell. I have fatigue. I have weight changes, cold intolerance, right? And then we look at the other pieces of the puzzle. Now, when we look at other things, one thing to note is that a hematocrit over 54% actually significantly raises clot and stroke risk. So whether that's happening naturally or whether that's happening for someone who's on, let's say, testosterone therapy, this is an important thing to keep in mind. 2 more things I'm going to note about the red blood cell and hematocrit is chronic smoking. Carbon monoxide from cigarettes actually binds to your hemoglobin and blocks oxygen delivery. The body compensates by making more red cells. So elevated hematocrit in a smoker is compensation, and it normalizes within weeks of quitting. So if you are a smoker, this is something to note that it might be elevated. And then we have a condition called polycythemia vera, a bone marrow disorder where red cells are overproduced, and this has nothing to do with that EPO pathway. The pattern is usually elevated red blood cells, elevated white blood cells, elevated platelets. This is more rare, but again, this can lead us to different patterns. And then we look at MCV. So this is the mean corpuscular volume, and this is also known as the size of the red blood cells. So MCV measures how big your red blood cells are, and the size turns out to be a really useful clue. So small red cells almost always mean an iron deficiency. Your body doesn't have enough iron to fill up the cells, so they come out small and pale. The main exceptions here can be certain genetic variants. So there's something called a thalassemia trait. This is more common in people of Mediterranean, Middle Eastern, South Asian, or Southeast Asian ancestry. And with thalassemia, the cells look small, but it's not because of iron. And giving someone with thalassemia iron is actually not a good call. So making sure that even on your own complete blood count, if no one has flagged, you have these weird things that are coming up in your CBC, does it look like thalassemia? Because you might be consistently told by healthcare providers that your iron is low when it in fact is not. Then we look at normal. So if you had a normal sized red blood cell, obviously normal is normal, but normal with low hemoglobin usually means something's affecting the production rate. So this can be something like kidney disease, chronic illness, or bleeding. So basically the size is fine, but there's not enough cells being made. So it's important to look at everything in relationship to one another. And then we have large cells. So an MCV that's over, let's say, just lost my window. An MCV that's over 100, this is large, this is macrocytic, and this can be due to a couple of key reasons. Large cells are typically B12 deficiency and folate deficiency. But one thing I wanted to note is that alcohol is directly toxic to the cells in the bone marrow that produce red blood cells. It disrupts their development, so often they come out oversized. If someone's red cells are consistently large and their B12 and folate are normal, alcohol is one of the first things to consider. And these cells can take months to normalize even after someone stops drinking, because we know that red blood cells live for about 4 months. So this is just something to consider. Then we have your RDW and your ferritin. So RDW stands for red cell distribution width. It's basically a measure of how similar your red blood cells are in relationship to one another. So normally the cells are going to be fairly uniform, like a bag of marbles, mostly the same size. But when something goes wrong with your production, you can start getting a mix. You can get old normal cells plus new abnormal ones. Now, the useful thing about using an RDW is that that'll often rise prior to hemoglobin dropping. This can be an early sign that something's gone wrong with your blood production. And then we look at ferritin. Most people use ferritin as being the same as both iron and hemoglobin, and that's not the case. Hemoglobin is the protein in your red cells that carry oxygen. Iron is what hemoglobin is made from. And ferritin is how your body stores iron. So you can have a normal hemoglobin and still have an almost empty storage, which is ferritin. So you can have symptoms like fatigue, hair shedding, restless legs, difficulty concentrating. Your hemoglobin looks normal. Your doctor's like, you're totally fine. But looking at other pieces like ferritin and serum iron can be really helpful because your hemoglobin might be the last thing to fall. By the time your hemoglobin falls, you already feel like absolute garbage. And when it comes to ferritin, most people don't feel their best until it's at least 30, but some people need it 50, 60, right? We have to look at, it's not just finding it within the normal range. And then we have a condition called hemochromatosis. This is where the body absorbs too much iron and stores it in places where it shouldn't. So usually the liver, the pancreas, the joints, the heart. Over decades, this actually causes organ damage. And the good news is it's completely treatable. You just donate blood and your iron levels come down. But often it's not caught until the damage is done. And so we need to, investigate further. Like I said, none of these pieces are stopping here. There's the diagnosis, moving on. But essentially it's giving you the next step. It's giving you a little piece. So, okay, next I should look at this. Next, we should do an ultrasound. Next, we should refer to a hematologist, right? Okay. RDW also rises. So your red cell distribution width can rise in mixed deficiencies. So if someone who's low in both iron and B12, your MCV, so the size of the cell, can look normal, right? Like I said, if it's a small cell, usually it's an iron deficiency. If it's big and dumb is kind of how I describe it. It's usually a B12 deficiency. But if you have both iron and B12 deficiency, that can look normal. And again, the small cells from the iron deficiency and the large cells from the B12 deficiency are just averaging each other out. But if we look at the RDW, this can catch if you have both deficiencies because the distribution is wide, even though the average looks fine. And so again, if everything looks normal and you are exhausted, your RDW could be telling you something that another piece of the puzzle is not. Okay. The other thing I always like to note about ferritin is the storage form of iron, but it also is an acute phase reactant. It rises in response to infection, inflammation, metabolic syndrome, obesity. And so what I find most often is a patient will have their ferritin tested. Let's say it's 45. It looks completely normal. The problem is that patient might be inflamed. That patient might have obesity, metabolic syndrome, and also have an iron deficiency. But because their ferritin came up 45, we're like, oh, it's great. Looks great. If we're not also running inflammatory markers and looking at concurrent inflammation, we're not able to determine, is that ferritin high or like normal because they have a super low iron and lots of inflammation, or is the ferritin actually looking good? This is where it becomes a little bit tricky, and we have to look at the whole picture, and we have to make sure we've really crossed our T's and dotted our I's, because we need to be able to differentiate what is going on. I find this hardest in women who have a period because usually those women don't have a really high ferritin to start. And so maybe their true ferritin's like 5, but it goes up to 45 with inflammation, making us feel like it's normal, but it's actually just a crap ton of inflammation. Okay. Other things that you can calculate from your white blood cells. So when we look at your white blood cells, there's a few different pieces to understand. Your white blood cells are your immune system. They're the cells that fight infection, respond to injury, and patrol your body for threats. And your blood contains several different types of white blood cells. Each has its own job. The CBC counts all of them together and then breaks them down by type. Okay. That breakdown is called the differential. So the total white count gives you not much information. The breakdown is where you can see a little bit more of the story. First of all, neutrophils are your first responders. These are the cells that rush to a bacterial infection or injury and they attack. They make up to about 50 to 70% of your white blood cells. And most people don't know that neutrophils also respond to stress and cortisol. So physical stress, emotional stress, poor sleep can all push up your neutrophil count. So if you get blood work done right after a stressful commute, a bad night of sleep, an intense workout, your white cell might actually look a little bit elevated. And it could be that you don't have an infection, but you're just having a stress response working. If you're taking steroids like prednisone, this can often push your white count up to levels that look alarming. But again, making sure that everyone who's doing your blood work knows what medications you're on is really important. Another thing I want to note is eosinophils. Eosinophils are a small fraction of your white cells. Typically, they're under 6%. They have two main jobs. They respond to allergies and they fight parasites, specifically worms. In Canada, the most common reason for an elevated eosinophil count is an allergy condition, asthma, eczema, hay fever. I am often looking at this just as an allergic response in general. If your eosinophils are raised, and then we again, looking at the whole picture, do you have more of like a histamine type presentation, etc.? We can use the eosinophils as an indirect marker. Also, parasitic infections will cause your eosinophils to rise. What I find interesting is when I talk to my patients and friends who work in the vet industry, they often will say, yeah, like when we see eosinophils rise in an animal, we're automatically like, all right, we need to treat for parasites. But for some reason, we just don't do the same thing when we test in humans. We're like, oh, yeah, no, it's totally fine. So when I see eosinophils, I think allergic, I think parasitic, especially when eosinophils are elevated. When someone also has a digestive issue, we want to think parasites being part of that. Also, just something to note, some common medications, certain antibiotics, NSAIDs, hormone medications, antidepressants can also increase eosinophils as a hypersensitivity reaction. So if you've started a new medication and your eosinophils are going up, then we need to think about the medications you're on as a first line. The other thing I want to mention here is this left-hand side here. If you're on Instagram, you probably can't see it, but if you're on my YouTube, you can. But this is your neutrophil lymphocyte ratio. This is another ratio that you can calculate yourself. This is not going to be on the report, but this is going to be something you can look at and write down and say, okay, I need to look at, again, we've looked at triglyceride HDL ratio. We're going to look at a lot of calculations when I go into the liver stuff. But the neutrophil lymphocyte ratio can be a really helpful tool to understand. So you're going to take the number of your neutrophils and you're going to divide it by your lymphocytes. Now, when we look at the range, less than 2 is considered normal. Over 3 can be a marker of chronically systemic inflammation, chronic systemic inflammation, and is related to higher cardiovascular risk. And over 5 is considered serious illness and major physiologic stress. So again, you're like, okay, I don't have inflammatory markers, but I have a ferritin that isn't, amazing. I have other things that are off. Let me just calculate my neutrophil to lymphocyte ratio to see if maybe there's a chance that my ferritin is not telling us the whole story, right? Remember I said ferritin's a marker of inflammation. So maybe we look at that ferritin, we're like, okay, my ferritin's 45, but I'm exhausted, I'm losing hair. I don't have anything else to go from, but I can do my neutrophil lymphocyte ratio, say that 10 times fast, and I can see, oh, it's actually over 3. Okay, so then my ferritin might not be telling the whole story with my iron. Maybe it's worthwhile to do a little bit more investigations into inflammation and iron, right? We can do these investigations anyway, but this can help you just map out what is going on. This is your blood work's normal, but you feel like crap. This is where we can really find nuance and look into some of these pieces. And then we have Lymphocytes and monocytes, these elevated persistently in older adults. We want to look for the most common adult leukemia. And then monocytes elevated can indicate a chronic infection, things like TB, autoimmune diseases. Platelets. So platelets are tiny cell fragments. They help your blood clot when you're injured. Too few, you bleed too easily. Too many, your blood is more prone to clotting. Again, it's that sweet spot. Interestingly enough, iron deficiency actually causes your platelet count to go up. Your body responds to that low iron by overproducing platelets. So again, if someone has low red blood cells, low ferritin, high platelet count, typically that's going to be an iron deficiency, even if hemoglobin is normal. And so we might decide to do a serum iron as well, as an additional layer. And then there's the liver connection. So your spleen is responsible for storing platelets. When your liver gets scarred from years of alcohol, fatty liver disease, and other damage, it creates an elevated blood pressure in the vessels around the liver, and the spleen can enlarge. A bigger spleen traps more platelets, so therefore the circulating platelet count is going to be lower. This is typically happening over years, and this can happen far before the platelets or the liver's own enzymes look alarming. So this can be a slow progressive marker. If your platelets are slowly going down over time, we might want to look into the liver and look at that from a liver scarring perspective, because we've seen this trend. Again, this is where trends are important, because you might still be well within the normal range, but over time, curiously, you're noticing within the normal range, platelets are going down. Liver enzymes are still normal, but like coming up, right? It's not something that we should discount altogether, but something that we should really pay attention to. And when we look at the CBC, it's really important to have just some pattern recognition. This is clusters that can reveal what's actually happening when someone's values look borderline. So, for example, we have high red blood cells, we have high hematocrit, and we have normal MCV. We might want to look at things like high testosterone, sleep apnea. If someone's a smoker, then we can, rule that to smoking. Not that I'm saying that it's good, but we have an answer as to why it's happening. Classic iron deficiency is like low ferritin, high RDW, low red blood cells, low MCV, and you may or may not have low hemoglobin. When we look at something where it comes up normal B12, normal folate, but you have a high MCV, again, your cells are really big, but we've ruled out B12 and folic acid. We might want to look into the liver, chronic alcohol use, hypothyroidism. These are the things you're like, oh, everything's normal, but weirdly my MCV is coming up high. Well, we might want to look at the thyroid, might want to look at the liver, or if there's a lot of alcohol use, then we want to attribute it to that. When we see your platelets dropping, a trend over time, a rising MCV, right? Rising size of your cells, and a borderline liver enzyme. We want to investigate the liver before it becomes too late. And if we have elevated eosinophils, I would always investigate parasites, allergies, that kind of allergic response. Eosinophils are really helpful for that. And then again, if we have really high ferritin, elevated transferrin, a lot of fatigue and joint pain, if we also have elevated liver enzymes, we want to look into hemochromatosis. Okay. Next up is the liver enzymes. A lot of people think of the liver as the organ that processes alcohol, but the liver does about 500 different jobs. It filters your blood, it makes proteins, it produces bile for digestion, it stores glucose, it breaks down medications. I also want to note your liver processes supplements. And so when I talk to patients who are on 5 million supplements for reasons I can't understand, right? Like, again, if there's a reason why we need to be on, 6 or 7 things, then, we have that conversation. But your liver is responsible for processing everything you put into it. And so there is a real conversation to be had. Where is the balance between taking too many things, that your liver can't end up processing, and taking things that are going to benefit your health? The test I'm looking at here is ALT and AST. These are two enzymes that live inside liver cells. And when those cells get damaged, those enzymes leak into the bloodstream. So what we're measuring is when they've already leaked into the bloodstream. So first of all, we're looking at ALT and AST. Okay. This is typically, if your doctor's done quote unquote basic blood work, it's more than likely ALT and AST is going to be on there. So the ratio between the two actually tells us a story. In fatty liver, ALT is usually higher than AST. When AST starts catching up or overtaking ALT in someone with liver disease, it often means the damage is progressing. And if we're at a point where AST is more than twice ALT, especially in someone who drinks alcohol regularly, this is a classic pattern for alcohol-related liver disease. Again, this isn't definitive. This is just a signal. So ALT and AST are inside the liver cells. When they're damaged, this can be by alcohol, too much fat, a virus, medication. They leak into the bloodstream. So when we look at the actual numbers, ALT is going to be more liver specific. AST is in the liver, but it's also in muscle, heart, and red blood cells. This is less specific on its own. And the problem is that lab ranges were calculated from populations with lots of undiagnosed fatty liver. And so a better threshold from an ALT perspective should be less than 25 in women, and an ALT should be less than 33 in men. A normal ALT does not necessarily mean your liver is fine, because as cirrhosis develops, as your liver gets more and more damaged, you actually have fewer cells to release those enzymes. So what can happen in cirrhosis and in liver damage is your ALT, it was high, and then it starts to normalize as the liver is failing. I'm going to give you another marker that you can use to look at your liver health in the next slide. But essentially, we can start by looking at AST divided by ALT. Okay. So we're looking at a number, and we're trying to figure out if your liver has any source of damage. So the first thing we're going to do is we're looking at it being less than 1. So we do AST divided by ALT, and if it's less than 1, things are usually fine. Over 1, this is in a fatty liver. Fibrosis might be progressing. Over 2 is classic alcohol liver disease, and over 4 is quite rare. Then we have FIB-4. This is a lot more applicable of a score that we can calculate ourselves. So write down FIB-4, because you can go online and you can look up FIB-4 calculator. It's going to be a lot easier. This calculation is quite complex, but this is basically telling you from your AST, your ALT, and your platelets, and we can see if we have any scarring or fibrosis on the liver. So you put in your age, your AST number, your platelets, and your ALT. You need to calculate the square root here, so it's easier to go on the calculator and just find that yourself. But anything less than 1.3 is low risk. So again, we're looking at the numbers, the trends, we're looking at the AST to ALT ratio, and we're looking at the FIB-4. This can all give us information along with the triglycerides, right? We're looking at our lipid panel, we're looking at our CBC, and we're looking at patterns, right? We're not saying, oh my gosh, I found this one thing that was wildly crazy, and now that means I'm dying. This is not what I'm telling you. I'm saying this is a way to look behind the curtain to see what's going on with your blood work that you probably have in your LifeLabs account right now. And the last piece of the puzzle is, how do these patterns talk to each other? So let's put all of this together. We've looked at some of these panels, the lipid panel, the CBC, the liver enzymes, they all tell part of a story. But again, we have to put everything together. So I'm going to give you a few different case scenarios why this is useful to look at. Okay. So first scenario is number 1. We have someone who's 29. They have low energy, hair loss, and heavy periods. Her hemoglobin is normal. Everything else on the blood panel, the CBC, the red blood cells looks quote unquote normal. She was told her blood work was fine, but she asked for her ferritin, which came up low. Again, your hemoglobin can look normal when your iron is depleted. Why? Because iron deficiency develops in stages. Your body is going to prioritize hemoglobin production above almost everything else. It's going to drain all of your other iron-dependent processes before hemoglobin lowers. So stage 1 your iron stores will be depleted. Ferritin will drop. There might be nothing that comes up in the hemoglobin. And women can sit like this for a long time. Stage 2 is where we have iron deficient erythropoiesis. Now the marrow is making red blood cells without enough iron. So the cells are going to start coming out fewer and smaller. So that can mean that your MCV can drop, your RDW can rise, and then your platelets can start to rise, but your hemoglobin is still normal. Then stage 3 is your frank iron deficiency. Hemoglobin finally falls below the threshold, but see how long we had to go for that to happen? Case 2 is someone who's 41, they have endometriosis, and they are exhausted. Their ferritin 62, and they're told they're fine. The problem here is that their ferritin looked fine, but it wasn't run with inflammatory markers, or they didn't have that calculation. Maybe the neutrophil lymphocyte calculation showed that inflammation was high. Endometriosis was causing inflammation. That means that ferritin went up when actual iron stores were super low. Case 3, we had somebody who's 44, weight gain, cold, hair thinning, TSH normal. So they had their thyroid done, a few years ago. It was in the high normal. It was 3.4. So it wasn't flagged, but they still have weight gain. They're cold, their hair's thinning. And they looked at the rest of their panel and nothing was crazy, but their MCV was rising over 4 years slowly. Their LDL cholesterol was rising, again, over a few years. And their ALT was like low-ish, normal, nothing crazy. But over time, we see these trends with a TSH that was high normal. The first thing should be to retest that thyroid panel to include T3 and T4. And in this case, somebody was diagnosed with hypothyroidism because we actually ran the thyroid levels after looking at the symptoms, the presentation, the blood work, the trends, and the movement over years. And then the fourth case is someone who is 36 with PCOS, now known as PMOS. They were getting annual blood work and they were told everything was fine. This one, I think, is the most interesting case because nothing was really alarming, right? So they had their lipids done, their triglyceride to HDL ratio, which is not in your blood work, right? It is something that you have to take, look at your triglycerides, look at your HDL, and you have to calculate that. So this was not in their blood work, but over time, their ratio slowly was creeping up. Again, marker of insulin resistance indirectly. Their ALT wasn't flagged yet, but it was going 22, 29, 36, slowly going up with the insulin resistance, liver markers going up. Hematocrit was 45% throughout, which if you look on your references, that won't be flagged yet. That's just on the cusp. And they had high red blood cells. So no single result is crazy in this blood work, but we see a creeping of insulin resistance. We see the liver accumulating fat over time, and we see markers of androgen excess. We see markers that their testosterone is a lot higher over time, right? Looking, again, we didn't measure testosterone. That might be the next step. We might do deeper insulin testing. This might be a really good time to do something like the insulin glucose challenge. But over time, we're seeing the accumulation of fat in the liver. So we're seeing this metabolic syndrome that's, growing over time. We're seeing excess testosterone and other things that we should be a little bit more concerned with. Okay, so questions to bring to your appointment. Again, these are things we can test. Lipoprotein A is something you can ask in addition to have tested that will help understand your cardiovascular risk in general. Again, this is something that explains why some healthy, lean, non-smokers have heart attacks. Number 2 is looking at your liver enzymes. You don't even have to ask this question. You can go online and look up FIB-4, and you can calculate your own FIB-4 with your age, your platelets, and your liver enzymes. You can calculate your own triglyceride to HDL ratio. You can look at, do you also have your FIB-4 high? Is your triglyceride to HDL ratio telling you that it's high? Then maybe you ask for an ApoB, right? So we can take some of this information and we can advocate for ourselves. Maybe we calculate our neutrophil lymphocyte ratio and we're like, ooh, that's showing some inflammation. Can I have my inflammatory markers tested as well? So this is some information that you can take to help build patterns in what you're trying to understand. And so The most important thing you can do with your blood work is read it over time, not in isolation. Of course, if something is, crazy elevated, we need to make sure that we're addressing that. But, when we look at our blood work, the trending data is really important. Values across years tell you where you're going, and it can give you a lot more information than just looking at, oh, normal, 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 not normal. So hopefully this was helpful. Some resources that you can go to is called the blood code. Blood code is something that you can use to use their calculators, and it will tell you like some of the reference ranges from an insulin resistance perspective and otherwise. So if you want to rewatch this will be on my Instagram, on my YouTube, but hopefully this was helpful in giving you at least a starting point on how you can understand your blood work a little bit more. And I hope everybody has a wonderful rest of their day.